Okay, good evening, everybody. This is our February 14th, 2022 NAC meeting. And our featured presenter tonight is Dr. Alan Melnick, who I'm sure many of you, I hope all of you know, is the Director of Public Health for Clark County and several other counties too numerous to mention. And he's going to talk to us about the current state of the coronavirus pandemic here and probably elsewhere in Washington, and what we can look forward to over the coming weeks and months. And I did, during our last meeting, solicit questions for Dr. Melnick. Didn't get very many from the other neighborhoods, but between Merrily and my fellow officers, we managed to provide a fairly extensive list of topics for him to address. So, Dr. Melnick, floor is yours.
Well, thank you. Can you all hear me okay?
Oh, yes.
Merrily, should I just share my screen or do you want to? Oh, you've got them. Okay. Well, that makes it pretty easy there. I'll wait until you get to the current. There you go. Great. Well, now I can turn it off on my screen here. So let me do that so I'm not looking at it twice. Okay, let's go ahead and go to the first slide. So just by the way, I was on a call with the CDC. I'm on the calls with them weekly, and I'll just do the national picture. So the good news is nationally, case rates are going down, hospitalizations are going down. I mean, they're still at high levels, but they're dropping. Unfortunately, at the national level, and I'll talk about the state and the county level, the death numbers are still ticking up or flat. But that's to be expected because the hospitalizations lag behind the cases. Takes a while for cases to become hospitalized, and then the deaths follow after that. So hopefully nationally, the deaths will be going down soon. In Washington State, and I'll get down to the county in a moment here, the case rates are decreasing. Now you could see on that graph there, if you go back, we're in that really high range. The bump before it was was a Delta surge. And remember how bad the Delta surge was. You can see how much higher our case rates have been with Omicron, and the 14-day, we look at rates over 14 days, and the most recent state data we have is through January 27th, when the case rate is about 2,740 cases per 100,000 population. You can see that's around, 5 times, or at the peak when we were over 3,000, we were about 5 times what we had seen during the Delta surge. But the good news is, as you can see on the right side of that graph there, it's going down. The rate of hospitalizations is also beginning to decrease. And right now, the 7-day rate is 26.4 new admissions per 100,000 population. That's over, again, a week. Again, the deaths remain high statewide, but are not decreasing yet. So we'll go on to the next slide, please. And this is the Clark County COVID-19 activity. So you can see that the numbers here are going down, but remain high. So our 14-day rate as of February 5th, and this is preliminary data, is about 1,627.6 cases per 100,000 population. Now that compares at the, it's going down, but and actually a week ago, it was over 2,400. So the 14-day rate up until the previous week was 2,400. So that was about a 33% drop. But that's still, even at 1,600, it's still 5 times higher. I'm sorry, several times higher. I say about 3 times higher. I know at the height of our Delta surge, it was about 550. So we're about 3 times higher than that, but it's coming down. And as I said, the peak rate in late January was 2549. So we've gone down about a third since then. Next slide, please. And this is the hospitalization numbers. The rate of hospitalization is decreasing. We got a little blip, but the 7-day rate is about 22 admissions per 100,000 population, and it's dropping from the peak. As you can see, our hospital beds are still pretty full. So 97% of beds are occupied. This is the thing that keeps me up at night. This and the deaths. The problem with when you don't have much hospital capacity is you have to delay. I hate the term elective procedures, because a lot of those procedures are actually, like cancer screening procedures, for example, do have health impacts. So elective is probably not the best word to use, but it has an impact on that. And also, if there's not much capacity and you have an emergent health problem, like a heart attack, for example, that could be a problem if there's no space, for example, in the ICU. And right now, as of February 5th, 98% of ICU beds are occupied. So that doesn't leave a lot. And as you can see, more than a quarter of the beds in the hospitals were occupied by COVID-19 cases and persons under investigation for COVID-19. And more than a third of ICU beds, same thing. So as of February 5th in Clark County, we had 107, actually we had 134 people hospitalized who were either COVID cases or under investigation for COVID. Just like the state, the deaths remain high and have not begun to decrease yet. There's one other point I want to make, because there's probably a lot of points I want to make. So as we continue to have more virus circulating, not only in, like Clark County or the state or nationally, but around the world, the more viruses out there, the more opportunities it is for it to mutate. So, and when it does mutate, we can get more new variants emerging. And this has happened in several places, like the Alpha variant came from the United Kingdom. The Delta variant arose out of India, and we've seen the Omicron variant out of South Africa. Another thing that keeps me up at night is, if we don't get the numbers down around the globe, is the development of another variant that could be as transmissible as Omicron and as deadly and cause severe disease as Delta. So I pointed out, you might remember during the Delta surge, and the Delta variant was more serious in terms of its health effects than Omicron. Omicron, fortunately, has been mild. Our rate of Omicron at the peak was 5 times that of Delta. If Omicron causes severe disease as Delta was, imagine the impact on our hospitals and the number of deaths. It's hard for me to imagine, especially when during the Delta variant, we saw our hospitals full as well. So these are the things that I worry about, and it is a global effort. Okay, next slide, please. But the good news is numbers are coming down. So the Omicron variant continues to be the predominant strain by far circulating in Washington and across the United States. And you've heard about the BA2 subvariant. It's very small, it is increasing. There's no evidence that it causes, it's significantly and maybe a little bit more transmissible. It's increasing than the original Omicron variant, but there's no evidence that it behaves differently otherwise. We're not really looking for it that hard. It's a subvariant, and the state isn't really looking at subvariants. They're looking at variants in general. I don't have any additional data on the percentage of cases attributed to the BA2, but I thought I'd mention it because it's been in the news. I think it was in the news a while back, but I thought I'd mention it. The other good news, beside the numbers coming down, is that the vaccines available continue to be very effective at preventing severe illness, hospitalizations, and death from infection with the Omicron variant. But we have seen that the number of infections among fully vaccinated people, which we also call vaccine breakthrough, has increased since Omicron became the predominant variant. But the early data shows that reinfections are also occurring with Omicron. So Omicron is more likely to cause a reinfection in somebody who's had previous infection with COVID-19, with the virus, the SARS-CoV-2 virus, the virus that causes COVID-19. And even though we're seeing more breakthrough cases, I'd also point out that the vaccines, and I'll show you some data on that, still prevent you from, besides severe illness and death, still prevent people from getting infected in the first place, even with the Omicron variant. And there's some new data out of LA, a study done that showed that to continue to be true. Next slide, please. So, so this is through January 22nd, when the Omicron has been the predominant variant, I think through, like December, since mid to late December. Case rates, hospitalizations, and death rates continue to be highest among people who are unvaccinated compared to those who are vaccinated. So the case rate was 6 times higher in in unvaccinated persons compared to fully vaccinated. 5.5 times hospitalization rate in those who are unvaccinated than compared to those who are fully vaccinated. And the death rate was nearly 7 times higher in the unvaccinated compared to the fully vaccinated. So in all ways, the vaccines are protective. And I'd also say that, looking at the recent data, that boosting really helps. Okay, next slide, please. So as I mentioned earlier, the case rates, even though they're going down, are higher than during past waves. So that means that people should continue to take precautions to prevent themselves from getting and spreading COVID-19. And that means getting vaccinated and boosted when you're eligible. And you can get boosted, if you, now it's not 6 months, you can get boosted in 5 months after the mRNA vaccines. Wear a well-fitting mask, face mask around others. And masking is effective, regardless of what you've heard on social media. That you might have seen on social media that cloth mask with multiple layers, a double mask, or wear respirators, N95s or KN95s for greater protection. I was looking at a study recently that showed cloth masks were prevented infection in people who wore them regularly. I don't know if I have the data here, but I've got it in my head. People who wore cloth masks routinely were 56% less likely to get infected. People who wore surgical masks, they did better. They were in the 60s, I think around 63%. And people who wear KN95s or N95s are 83% less likely to get infected if they wore than people who did not wear masks at all. So, or did not wear masks regularly. So they are really effective. That was a recent study out of the CDC. So masking is effective. Consider skipping, while case rates are still high, large gatherings events, especially if you're often around, people at home, for example, who might be at risk for severe illness. You don't want to bring it home. Obviously, stay home if you're sick, except if you need to seek testing or medical care. And certainly, the old adage about washing hands frequently, disinfecting surfaces is always a good thing to do. Next slide, please. COVID-19 testing continues to be available at medical offices, at pharmacies, and other testing sites. The demand for testing increased dramatically as case numbers surged. I think it may be going down now. The other thing is that, one of the issues with getting tested was that healthcare facilities had staffing challenges due to people out sick and more patients needing hospital care. So, and also the facilities needed to staff clinics offering vaccinations and therapeutics like monoclonal antibodies or antivirals. So some sites temporarily limited testing, but if you're having trouble getting testing, I would continue to try at any one of, at your provider's office or at pharmacies and other testing sites. And again, as I mentioned, the demand for testing has decreased as the numbers beginning to come down, and also now that home tests are much more widely available. Next slide, please. So in terms of at-home COVID-19 tests, there are two portals, web portals for the general public to order at-home tests. And these are free rapid tests. They're antigen tests. They don't check for the genetic material of the virus like the PCR does, but they check for the protein of the virus. And the only thing you need is a name and an address. And if you go to the federal site, it's really easy to do. I did it. You go to www.covidtest.gov, and you can get a kit with 4 tests per household. And then the Washington Department of Health program has www.sayyescovidhometest.org, and you get a kit with 4 to 5 tests per household. If you have trouble there, I know that the State Department of Health had closed the site down for a while, but as they got additional supply from the federal government, they reopened it. So if you have problems, try again. People with health insurance can also receive up to 8 at-home tests per person each month for free. And some insurers are providing tests through pharmacies with no upfront costs. Others require payment upfront, but your insurance will cover the cost as well. So testing should be available. Next slide, please. If you do test positive, the day you should stay home and away from others, and you need to isolate for 5 days. The day that symptoms develop is day 0. So day 1 is the first full day after symptoms develop. If you're thinking about, what's day 1, 2, 3, 4, and 5. You can end isolation according to the new CDC guidelines after 5 days if you've been fever-free without fever-reducing medications for at least 24 hours and other symptoms are improving. But you should, and even after the mask mandates are lifted, you should continue to wear masks for at least 10 days, 10 days after symptom onset. But you can end the isolation after 5 days, as it shows here. So wear a full mask around others, avoid traveling. That's even after the days of isolation. Avoid going to places where you cannot wear a mask, and avoid being around people at high risk for COVID-19 illness. So you do need to continue to wear a mask, but you can end isolation after the 5 days. And even if you're in an area without mask mandates, you should wear a mask for the full 10 days after symptom onset. And if symptoms aren't improving, I can't see the slide now because of the chat. Let me see if I get it. Okay, now I can see it. If symptoms aren't improving after 5 days, or you can't wear a mask, then you should continue to isolate at home for the full 10 days. Next slide, please. Vaccinations, as I've already mentioned, continue to provide the best protection. Cases, infection, hospitalization, and death, and a booster dose increases protection. Now everybody 5 years in age and older is eligible to get vaccinated, and Pfizer is submitting data and a request for an emergency use authorization for children 6 months through 4 years of age. And the way that works is they submit it, the FDA, Federal Food and Drug Administration, reviews it. If they approve it, it goes to the CDC, and then if CDC approve it, it goes to the Western states. I think it's called Safety Commission or something like that. And once they approve it, then that becomes released here. Hopefully that will all happen within the next few weeks. Everyone 12 years of age and older is eligible to get the booster vaccine, not indicated for the 5 to 11 group. And I forgot to mention, so I did mention that you can get a booster 5 months after receiving the second dose of the Pfizer and Moderna vaccine. You can also get, if you've had the Johnson & Johnson vaccine, you can get a booster 2 months after that. And you can mix and match on what your booster is, between the different vaccines. People who are fully vaccinated and receive their booster dose when eligible are now considered up to date on their vaccinations. And that may be the the terminology that's going forward. We may drop the fully vaccinated term at some point and then consider up to date. Got a question there. What will a second booster be necessary? You know, we're going to continue to monitor how immunity does, you know, over time, and also look at, you know, breakthrough infections over time. I wouldn't, you know, I can't predict whether a booster, a second booster will be recommended. It wouldn't surprise me. I mean, I hear a lot of comments that, oh, you know, we don't know what we're doing. You know, we had to add boosters. I'd point out that many other vaccines that are around, including the vaccines that are required for school entry, require multiple doses. Just for example, for several examples, polio vaccine requires multiple doses. The whooping cough pertussis vaccine requires several doses. The tetanus, you know, and actually we added the pertussis, you know, the tetanus and diphtheria vaccine now includes, you know, Tdap now includes pertussis. We added a dose a while back to adolescents and then to adults on that one. The measles vaccine, you know, originally was one dose, 93% effective, and then a second dose is added to make it 97% effective. So this wouldn't be the first vaccine in history by far to require multiple doses. So it's a possibility. And the CDC just put out recommendations that for people who are immunosuppressed, the original series was really 3 doses for people who had immunosuppression. And then now there's a recommended booster dose for people who are immunosuppressed. And if I remember correctly, it's about 3 months after the last, the series. And I don't know if I have that on the slide, but, and I believe it's 3 months. I may have to check myself on that one. Next slide, please. The new report from the CDC, and this is what I was mentioning, this is the LA study that showed that case and hospitalization rates are highest among people who are unvaccinated and lowest among people who are fully vaccinated and received a booster dose. And this was looked at in LA County. A large number of people were studied, and this was the Delta variant, the Omicron variant became predominant in mid-December. So this is looking at Omicron. And the case rate was 3.6 times higher among unvaccinated compared to people who are up to date, who are fully vaccinated and boosted. And the hospitalization rate in unvaccinated was 23 times higher. So if you haven't gotten your booster yet, I strongly urge you to go ahead and do so. Hopefully you're all fully vaccinated and boosted. Next slide, please. I'd love to get vaccination rates higher in Clark County. Now that we know how many children, you know, we have data on the 5 to 11-year-olds. So the eligible population are those who are 5 years of age and older. Right now, statewide, about 70% of that population is fully vaccinated. In Clark County, it's about 64%. So that means we've got more than a third of our eligible population still unvaccinated. And if you use a denominator, the total population, we're a bit lower. So if you look at that chart there, if you consider the total population, which include, you know, people under 5, only 60% of the population has completed vaccination. So 64% of the eligibles. And that compares with those numbers at the state, 64 and 71% versus 60 and 67%. Next slide, please. And here's a vaccination by age. Certainly we're doing better in the older population, and that's good because they're most at risk. At the 5 to 11 age, we've got about 20%, 1/5 of our 5 to 11-year-olds fully vaccinated. And when I've been looking at the state dashboard and looking at rates of COVID-19, they're higher in the younger age groups, you know, the school-aged kids and teenagers and young adults. And you can see the numbers go up as the age grows up. Next slide, please. So I hope I'm getting to all the questions that were asked. One of the questions asked is about the how you provide proof of vaccination. So the Washington Department of Health created a digital record verification system called WaVerify, and you can get to it called waverify.org. And I just did this quickly myself earlier today. I've done it in the past. It works really easily, and you can do this in a few minutes. You provide your name and your date of birth and an email or phone number, and you will receive a link. This happened within seconds to download a QR code and a digital copy of your vaccination records. And this uses it on the based on the WAIS, the Washington State Immunization Registry. And if you get a vaccination in Washington, your provider should be entering it into the registry. And if you get a vaccine at a pharmacy, that's a provider, they would be doing it as well. And the digital record and these QR codes are additional options. If you don't want to take your paper card along, these are additional options for providing proof of vaccination. And you can even use it for travel. So, I also have I took a photo, with my phone of my immunization card. So I use that as well, but you can use the QR codes in the digital record. And if you need any help with this, or if your records, there's something wrong with your records in the state database, contact the COVID-19 hotline, and the number is there on the PowerPoint, which I'm sure we can share with you afterwards, and I think it'll be available in the recording. But if you need assistance, you can call that hotline number. And if there's also concern that your provider didn't enter the information correctly, you can talk to your provider, because your provider can access the database, the WAIS. Next slide, please. I already mentioned, I'd give you the numbers earlier. Face coverings are an effective tool. This is a new report from the CDC. I anticipated myself here that this looked at indoor mask use among California residents from February to December of 2021. And as the science is pretty clear around masking. So I think I was a little bit off on my percentages. I think it was pretty close. So I was talking about this a little bit earlier. Masks reduce your made the folks 56% less likely to get COVID-19. Surgical masks would made the participants 66% less likely, and the respirators, N95s and KN95s, 83% less likely. People were less likely to get infected. So I know there's a lot, I spent a lot of my time trying to counter the information that's out there, but the two main points: vaccines are effective at preventing infection, besides preventing severe disease and death, and masks are effective in preventing infection and protecting people. Next slide, please. Local pharmacies are distributing free N95 masks to the public. And by the way, I know there were questions in the chat about the federal supply. I think we got ours within a couple of weeks when we ordered and I think some other folks were answering questions in the chat about that as well. Be happy, we can share our experiences there. Several community organizations are distributing free masks to the public. And locations are announced once the sites receive their masks and begin distributing them. And you can also purchase masks in local stores or through online retailers. And I was talking about a second ago, through ordering through the feds was not, I don't know about getting the masks. I think they were pretty quick, but testing supplies as well, I think it's within a week or two. But the pharmacies, you can get masks from there, and you can also get them through local stores or online retailers. And I'm sorry if I'm confusing folks about test supplies and masks. Next slide, please. As the case and hospitalization rates begin to decrease, the governor is and the State Department of Health considering when to lift the indoor mask mandate. You know that the governor made the announcement about the large outdoor events, and I believe February 18th is the day that goes into effect, where the outdoor mask mandate for these large events is dropped. In the meantime, face coverings are continuing to be required in indoor public settings and schools. I believe that the governor may be making an announcement. As you know, our neighbors to the south, the Oregon governor listed March 31st, I believe, as the indoor mask mandate. That will be the last day that there would be a mask mandate indoors. It may be dropped earlier than that. The Governor Inslee, may be doing something similar this week. I believe he generally does press conferences Wednesday and Thursday. So I think we may hear this week. Masks may continue to be required even once they're dropped in those other public indoor settings. They still may be required in healthcare facilities, other settings. The federal mask requirement for public transportation will remain in place. That's set by the feds. And you can certainly choose to wear masks indoors, and masks may be still recommended for some people, such as those at higher risk for illness or children who are too young to be vaccinated. Next slide, please. Okay, so one of the questions I got asked was about COVID-19 fatigue. And I'm going to want to address that here. And I may have, you see, okay, I'll get to that in a second. So pandemic fatigue, I mean, we're all tired of this. We've been dealing with this for 2 years now. And, I remember when we all went into starting to work remotely. I think it was March of 2020. So we're pretty close to that. It's a natural and expected response to the prolonged stress that people are enduring. I mean, we've been in a near constant state of vigilance for the last 2 years. And the stress comes from not only what we're experiencing, but the emotional and cognitive energy need to continually respond to uncertainty and changing circumstances, and even the recommendations changing over time. Even daily activities. I know, I'm sure folks on this call have questions. People ask me questions. We respond. Our staff gets a lot of questions, day-to-day questions. How many masks do I wear to the grocery store? These are just example. People with, there's been a challenge with childcare and people managing childcare who are working in when childcare centers close. What if I develop a cough? Is it COVID? Where do I get tested? Lots of questions, should we get together with friends and family? And then the other challenge around fatigue, and actually this is fatigue for me, because I keep on responding to the misinformation that's out there, is that the proliferation of misinformation about COVID-19 can lead to people doubting recommendations and not even perceiving the pandemic to be serious anymore. And, there've been all kinds of questions about effectiveness of masks and vaccines. I've heard lots of questions about infection-induced immunity compared to vaccine-induced immunity. I want to, and the term, I like the term infection-induced immunity versus natural induced immunity, because the word natural connotes superiority, the term, and as if the vaccine is unnatural. Vaccines work on our natural systems here, our immunologic systems. And so I try to use these terms. I point out that the data show that vaccines are more effective than infection in providing immunity. And there was a study out of, I think it was Kentucky, that showed that people who had previous infection Those who are vaccinated following their previous infection were almost 2.5 times less likely to get reinfected than those who did not get vaccinated after being infected. And I would strongly recommend folks who do have an infection, who have had an infection, to get vaccinated if they haven't done so. I also want to point out that getting sick is a poor strategy for getting immunity. The reason we vaccinate folks is to prevent them from getting sick, getting hospitalized, and dying in the first place. And taking a risk to develop immunity by getting the disease is not a good strategy. And I've still heard, I mean, I've been doing this work for a long time, but I've still heard people having chickenpox parties with their kids to intentionally get them infected so they have natural immunity. You know, the name chickenpox, I like to call it varicella, may sound, like it's nothing to worry about, but it can have, you can get varicella pneumonia, for example, and it can be deadly. So getting an infection is not a good strategy for getting immunity. And in terms of the seriousness of the virus, it's just the flu. I want to make a point there. In the worst flu years in the United States, we get 30,000 to 50,000 deaths from the flu. In a period of 2 years with COVID-19, we've had close to 1 million deaths. That's per year. That's 10 times the mortality of influenza. And it's been similar in Clark County, where we've had at least 10 times the number of deaths per year here compared to what we would have in a bad flu season. So it is nothing like the flu. And even the Omicron variant, even though it's milder than the earlier variants, this is not your flu. Although, I see that and hear that all the time. Okay, next slide, please. And as a result, pandemic fatigue can lead people to be less motivated to take, we're all getting tired of this, protective measures like masking, distancing, avoiding gatherings, and less likely to seek COVID-19 information. This occurs, we get complacent a bit. The perceived threat may decrease as people get used to it. And for some people, the perceived cost of being vigilant and doing the recommendations may start to outweigh the perceived risk due to the virus. And I've heard another misinformation I've heard is, the vaccine is more serious than the infection. Not even close. The vaccines are incredibly safe and very effective. The urge, you've heard this, for self-determination and freedom grow as restrictions continue. And complacency, again, as people get used to the pandemic and the threat it poses. In terms of the, around the world, the developed countries are doing a lot better than the developing countries. If you compare the United States with developed countries, we're not at the top of the list. And unfortunately, I don't have the numbers for you, but I think the Johns Hopkins site might have national comparisons, and I can't remember exactly where we are, but we're nowhere near the top in terms of vaccination rates in the United States. That might be my last slide, but I want to read you something in terms of complacency. This was a poem that actually, I want to read this to you about fatigue. It was actually put together by a writer who's a columnist for the Catholic News Service, and her name is Laura Kelly Finucci, and she has a nationally syndicated Faith at Home column. It's in Catholic newspaper. She's also been featured on NPR Morning Edition. And anyway, I thought it was this had a lot of meaning to me, so I'm going to read it to you. But it's called "When This Is Over." When this is over, may we never again take for granted a handshake with a stranger, conversations with neighbors, a crowded theater, Friday night out, the taste of communion, a routine checkup, the school rush each morning, coffee with a friend, the stadium roaring, each deep breath, a boring Tuesday, life itself. When this ends, may we find that we've become more like the people we wanted to be, we were called to be, we hope to be, and may we stay that way, better for each other because of the worst. So, to me, I'm hoping that as horrible as this has been, and I see some light at the end of the tunnel, that we actually come out of this more resilient and really, have a great concern of, for our neighbors and folks around us and for our community. So I'm hoping we come out stronger, as horrible as this has been. So I'll leave it at there, and I'll stop, and I'm happy I can look at the chat and answer questions folks have.
Dr. Melnick, I have one question, and that's concerning the symptoms. And I've been checking my temperature regularly. How often is a fever part of the symptom?
I don't know I don't know the percentages, but fever is a hallmark of that. But there are a number of people who are asymptomatic as well. I mean, there's a wide range of, so I can't give you the percentages, but I mean, fever, I don't know that off the top of my head. I'd have to get that for you. But I'd also be, paying attention to other respiratory symptoms. And as you know, one of the hallmarks, but you don't have to have it, is a loss of smell and taste as well, which can linger at times. But certainly, it's a respiratory virus, so certainly respiratory symptoms. But in terms of the frequency of fever, I think it also depends. I mean, elderly people in general are less likely to get fevers than younger people, but that varies as that's true for a lot of infectious diseases. But I don't think you can use that alone. But certainly, and also, how likely is a fever to be COVID-19 really has a lot to do with how frequent, what the community rate is. So, if we get to a point that there are very few cases in the community, having a fever, and not having had any exposure makes it a lot less likely that it's COVID-19. But I don't know, I'm not aware of any studies, and I could look it up, where it was actually looked at what percent. I'm sure the data is out there, and I can get it for you, and I could provide Marilee that information that she could share with everybody in terms of, the percentage of, if you've got a fever, what percentage of people with COVID-19 have fever.
Okay, thank you, doctor.
And it's also hard because a lot of people never get, have asymptomatic infections and don't get tested. So we'll never know.
Mm-hmm. So I had a question, because I went almost the whole 2 years with staying healthy, and then my granddaughter came and stayed here for the weekend over Martin Luther King Jr. weekend, and I wound up contracting COVID within 3 days after she was here. So I have concerns that unmasking the kids at school, am I just going to wind up saying she can't visit here? And I also, so that's part one of the question. And then the second part of the question is, do you have a concern that the cases are going to go up if they decide to unmask the kids at school? And then if we decide that we've got to go backwards again and start masking people, the struggle to get them to do so, with everyone being so fatigued over the efforts. We were talking amongst the people and that are the PIOs when we were out at the sheriff's memorial. And one of the suggestions that came from somebody that was out at Cressa was wondering if they had ever considered doing something like the fire danger in the woods, so that it's not we're unmasked or we're masked, but it's like, okay, the cases went up and we're in yellow zone. So this is what we're going to do in yellow zone. And then the cases go back down, and then we go to green zone. And then if the cases go back up again, then, oh, wait, we're in red zone again. And that might make more sense to people than just all the restrictions are off or all the restrictions are on. So the first part was if you were concerned about if cases were going to go up, and the second was if that type of method had been it was being considered.
Well, those are great questions. So let me see if I can tackle it. By the way, one of the things you pointed out is that, the Omicron variant has seems like a shorter incubation time. So you got sick within 3 days of being exposed, which is what we're seeing. So in terms of the governor's going to announce, I'm not sure exactly what the governor is going to announce this week, but I'm hopeful that he's not going to say we're stopping the mask requirement today when rates are really high, but he'll be looking at this. He's going to announce that at some point. I don't think we're going to have mask mandates in schools forever. So I'm cautiously optimistic that our numbers are going to continue to go down for a couple of reasons. One is that at least in the next couple of months. One is because we've got close to 70% of the or 64% of the eligible population vaccinated, and the other is that we've had so much infection that we've got a large other part of the population that's been has some immunity from being infected, that the virus will have fewer places to go, and we're getting closer to what you might call herd immunity. And that being said, I'm concerned about people who've been infected and don't get the vaccine, their immunity waning over time. So we could down the road see another surge and a new variant and all that. But with the cautiously optimistic piece, if the infection, the numbers go down significantly over the next month or so, and we get to very low rates, I think the decision around masking will be, the governor and the state superintendent basically said it'll be a local decision. That will be a discussion I'll be having with the schools and the superintendents, because it's a district decision, about whether they'd want to reinstitute a mandate. As a health officer, theoretically, I could do that. I think it would be, with low rates, I think it would be virtually difficult, it would be almost impossible to enforce. That being said, so it would be a decision we all make together. That being said, if the rates get really get low, people who are really concerned, you can still protect yourself by making sure that you're vaccinated and boosted, and you can still choose to wear a mask if you want to. And I think we'll probably see some of that continue. I honestly, for myself, looking down the road, I could argue that, that I may want a mask in future years. I mean, we've seen very little influenza over the last 2 years. And I have to think, and I think the CDC suggested that this is likely, is that masking during the flu season is not a bad thing to do to protect yourself from getting the flu. So I'm giving you a long-winded answer to the question, but I think there are ways that you can protect yourself once the rates come down significantly, and by getting fully vaccinated and masking voluntarily. And I don't see the mask mandate, for indoor, if the numbers continue to go down as they look, continuing for much, for a long time here. I think it would be untenable, especially around, the fatigue that we're talking about. Now that could be, so the other thing I'd point out, the other strategies that I can see down the road, and I'm sorry I'm talking so long here, but you all asked for it, so I'm doing it. But if the number right now, with the numbers as crazy as they are, and the incubation period as short as it is, case investigation and contact tracing are not effective. There are just way too many cases, and we can't get to them in time to identify who their close contacts are. But if COVID-19 remains a notifiable condition and the numbers get low, we will be able to investigate cases and identify their close contacts, and actually recommend, isolation for the cases and quarantine for the contacts, to provide additional protection in public settings, including schools. Possibility is that, it may be removed as a notifiable condition. In that case, and if the numbers get down really small, and the deaths are really down to where they're like at the flu, our response down the road may be very similar to what it is, what it is for the flu. Like, so if we see, numbers are down, but we have like pockets of cases or outbreaks, we may respond to them like we do with the flu. For example, I was talking to the superintendents about this. We have an outbreak of respiratory illness or gastrointestinal illness in a school. If you've got 10% or more of the kids affected or too many staff affected, it makes sense for them to maybe close in a situation like that. So our response could be different. Another scenario that you pointed out that could happen is, we get a new variant that is more contagious, doesn't respond to the vaccines, is more lethal, and we see that coming our way, then our response may be completely different. And everything I just said would go out the window, and we have a very different response to that. So I'm doing a lot of speculating here and thinking about this. I think the best path out of this, and this is true globally, and the best way to protect ourselves is true locally, statewide, nationally, and globally, is to get as many of us as vaccinated as possible right now and get boosted as necessary. But that's a long-winded answer. And I don't even know if I completely answered your question about that, Marilee. Well, we have like warnings on metrics. I think that was another thing you asked about. We'll be continuing to look at the case rate. Looking at the test positivity doesn't help so much anymore because a lot of people are doing tests at home and not reporting them. Looking at the case rate is going to be more challenging because a lot of people are doing their tests at home and not reporting them. So we're underestimating what the case numbers are right now. We can look at hospitalizations, but those lag, using that as a metric is not the best metric to use because the hospitalizations follow the cases by a couple of weeks. And by that time, you're already behind, and certainly using deaths as a metric lags even further. So we'll probably have to use a combination of metrics in terms of, what kind of warning sign we're going to put up. That's not very, and the other thing we sometimes use is something called syndromic surveillance. And what syndromic surveillance is looking at data that indicate that without test availability, that indicate we may have an outbreak going on. And that is looking at things like visits to emergency rooms for respiratory illness or fevers or something like that, or the amount of cough syrup or aspirin that people are buying and stuff like that. That's called syndromic surveillance. And we may be using tools like that as well. I can go on and on. I apologize.
Doctor, what about wastewater
Yes.
testing?
Yeah, and actually one of our, and I can't remember which one it is. Thank you for bringing that up. Another surveillance system is actually doing wastewater surveillance. So you can actually sample wastewater, sewer, and you can actually look for the SARS-CoV-2 virus. And you can actually, if you get enough material, you can actually do sequencing on that as well. So thank you for bringing it up. That's another potential tool that we will be using down the road. And where there's some studies going on right now nationally, and I think we have a water system here in wastewater system here in Southwest Washington, Clark County, that's participating in that. And so we'll have more data around that. That's a really good point.
Thank you.
I think Cheryl has her hand up.
Unmuting. Katie had a question in the chat, and I wanted to follow up on it too, about whether a second booster would be necessary and maybe a time frame on that. If they do, have you heard anything on that?
Yeah, I think I discussed that a little bit already. I think it's too early to say. That's okay. I think the CDC and all of us will be monitoring, not only looking at, like serology or antibody levels over time, but looking at reinfections in folks who've been, fully vaccinated and boosted, and there may be recommendations that change over time. I think I already mentioned that
Oh,
For people who are immunosuppressed, the original recommendation was for 3 doses, and now the recommendation is for actually a booster dose in folks who have been immunosuppressed. So that recommendation has changed. And I think I also mentioned that, doesn't mean that there's anything wrong with the vaccine. Many other vaccine preventable diseases require multiple doses. I think I mentioned polio, whooping cough, tetanus. We all know that we get those boosters, every 10 years. So it wouldn't be unusual. And that, that's been typical for vaccine preventable illness for, well, actually a couple of centuries. So it wouldn't surprise me, but we're not there yet.
and then I wanted to ask about masking. There was a little blurb on the news where they were saying that the cloth masks weren't as effective, but they also recommended doubling the surgical mask if you didn't have access to the N95. Does that help any or not?
I think it probably does, double masking. But I mean, I think I put the numbers up there. I think the surgical masks are about, I remember 60-something% effective, and the N95s are, but N95s and KN95s should be freely available right now. I think you should be able to get those, and I would recommend those.
Right.
So is there a test to see whether you've had COVID and whether you have any natural immunity? I don't see many research numbers on both those who have had COVID and those who might have natural immunity because they've been asymptomatic or something. Like, what percentage do we think in combination have had it and don't know they had it?
Yeah, that's a really great question. So let me get to part of that. So unfortunately, with SARS-CoV-2, with the COVID-19 disease-causing agent, so you can do serology, which is testing for antibody levels. Unfortunately, we don't have a good correlation between what your antibody level is and your immune status, your immunity. So it probably means you've seen the virus, but it doesn't mean you're immune to it. I know when, you might recall our measles outbreak in 2019. Measles and measles vaccine has been around since, the live vaccine has been around since the early 60s. We have good data on the level of antibody levels with measles and whether you're immune or not. And I was able to use that when we were deciding whether people were, who had, like adults, like for example, staff in schools, when we had that measles outbreak, whether they were immune or not. If they didn't have a record of 2 vaccinations, I was able to use serology antibody levels to say, okay, you're okay to be in school. So we have that data for measles. We don't have that for COVID-19. So if you were to go in and get a serology and show some antibody levels, I could not tell you that, oh wow, you don't have to worry, you don't have to get vaccinated. We don't have that data. And as I mentioned, people who've been previously infected are 2.5 times less likely to get reinfected if they get vaccinated after their infection. And the other problem is with Omicron, with this new variant, we're seeing more reinfections than we had in the past. So in terms of surveillance to see what percentage of the population has met the spike protein, I don't have the data offhand for you. And I know that there was a study done a while ago in Washington, but that was a while ago. And I don't have any recent data to give you an idea of how many people have been exposed, but unfortunately, you can't translate that exposure to like what percentage is immune, if that makes sense.
Okay.
I wish I wish we knew that. Yeah.
It's just a lot of people who are fighting the mask mandate and that sort of thing say that they have natural immunity because they've already had COVID. And
yeah, believe me, that one. And I think a lot of people, certainly a lot more people than people have been vaccinated have been exposed to the virus. So a large population has. but translating that into immunity based on measuring antibody levels is not, it does not work. And the evidence so far shows that a vaccination provides more robust immunity than than getting infected. The other thing I'd point out in doing these studies is that, you know, you can do a study about looking at people who are previously infected and comparing that to people who are vaccinated. The problem here is we know who's been vaccinated. We know the whole, because that's entered into the registry when you get a vaccine. When we're looking at people who are previously infected, the people we're looking at were people who were infected and actually got tested. And a higher percentage of them are sicker, because if you get sick, you're more likely to get tested. There's a large number of people who have been previously infected who never get tested and don't know they were infected. So when we do studies about so-called natural immunity, we already have bias in those studies because we're studying the people in general. A subset of the population have been infected, have been sicker. And given how sick they've been, they may have a higher level of immunity after recovering from it. We're also excluding the people who died, who are previously infected. So you don't have a good comparison group, having done research, it's not a good comparison group to use. So
Right.
that's another challenge as well. I'm probably giving you more detail than you ever wanted to have, but I just want to share it with you. So the information out there that you're better off if you get infected, no, not from the data we have. And as I mentioned earlier, getting a potentially lethal or a disease that could cause you long-term effects is not a good strategy for becoming immune. And another point I want to make is that children are not immune to this disease, and hospitalization rates have gone up in kids. I think somewhere around 1,000 children have died nationally from this. I don't have I know a few months ago it was 800. It was over 800. I think it's higher than that now. It is in the top 10 causes of death in children. So it's not. I know people are saying, well, we haven't had any children die in Clark County. That's true. But that's a pretty small sample size, and we have seen. And the other issue that we're learning about, including in children, is what are the implications long term in terms of potentially long COVID symptoms, or long COVID problems. So getting exposed and getting the disease is not a good strategy for developing immunity, and especially when we have an incredibly safe and effective vaccine.
Fair enough.
Okay, I'm sorry if I sound like I'm pontificating. I apologize for that too. So,
Oh, it's great.
I think that one of the aspects of the pandemic that people have a hard time remembering is that this is truly, at least as far as the human species is concerned, a new disease that we still don't know very much about. Even though it may be related to SARS, it doesn't seem to have the same clinical course. And I think it's rather unfortunate that epidemiologists, I don't know who started to use the terminology, but I think considering how new it is and how little we know about its natural history, I think it's unfortunate that people have started to use the term booster, because that's a term that's usually used for vaccinations protocols for diseases that have been around for generations that we know a lot about. And what people seem to be taking away from this is, well, this is experimental. They don't know what they're doing. And so they have to keep adding injections because they don't know if it's working or not. And fundamentally, because the disease was so scary and so sudden, we ended up with tremendous public pressure to get vaccines publicly available before we knew how long the immunity lasted, what the vaccine was actually doing in terms of preventing serious disease or death versus keeping people from getting infected. I think we've just tried to rush how much we think we know into too short a time span. There's my pontification.
Well, that's interesting. Personally, I consider it a miracle that we got as an effective vaccine. When you look at the numbers that quickly, I think there's a lot of criticism I can put at in terms of what we've done. I think the main issue, one big issue is communication, and it's difficult.
Yeah.
Because the science, the knowledge, as you said, it's a new virus, and the knowledge changes quickly over time. But I think we could have been a lot more transparent and aligned nationally, statewide, and locally. And I think we're still making mistakes along the way. And I think, we can all do a better job of listening. But I think, we in public health like to, we want to make sure we get we're scientists as well. So we want to make sure that we give the right information, but sometimes the language that we use is difficult. I definitely think we need a better job of communicating this. The other concern is, this is my issue here is I try to, to me, this is not a political issue. This is a public health issue, and somehow this thing has gotten politicized. It's not the first time this has ever got politicized. The issue about vaccine mandates was actually taken care of by the Supreme Court. I think it was in 1905, the U.S. Supreme Court in Jacobson versus Massachusetts during a smallpox outbreak when there was an outbreak going on, and I think it was an adult and a parent and a child refused to get vaccinated. I don't remember the exact story. You could look it up. It's Jacobson versus Massachusetts. But somehow this has become a political football about, and I'm concerned about that because, we've had vaccine requirements for schools, and you can see what happened with our measles outbreak, but I'm concerned we may be dialing back in the other direction and relaxing some of those things. So I have concerns about that. But I think it's been a struggle, but I think we could have done a better job communicating all along, and we're continuing to learn about that as well. Well, that met with silence there, so I apologize on that.
Well, you get into all sorts of other issues then.
If you all have feedback from me, first of all, I really appreciate everything you do, because you help hold, the neighborhood associations and your community service. I'm honored to be here and that you had me here. But if you have feedback for how we could be doing a better job, especially around communicating or listening or whatever we need to do, please feel free. You can, tell me something now, or you could send me a note or whatever. But if you have recommendations on how we could be doing a better job, please let me know.
Well, Dr. Melnick, can you figure out how to make people open their brains and listen? Because I think that's a problem. They don't listen to what they don't know about. Fear of the
this is totally inaccurate, and I apologize. This is being recorded. I don't know whether there's a behavioral health term called the Dunning-Kruger effect, and I'm not sure how accurate it is, but you probably heard about it, correct? So I'm amazed at how many folks, when I look at social media, how many people are out there, pontificating about this, but don't have any basic understanding of it. And our communications specialist spends a lot of time trying to, if you look at our Facebook page, trying to address that. But it's a challenge. I think it's also a challenge when you've got folks in prominent positions who are spreading misinformation as well. So that makes it pretty difficult.
Looks like Malata has a question, and then Judy.
Okay, here we go. It's finally unmuted. I had texted to you, Dr. Melnick, a question about some of the veterans. And does the Washington Verify keep track of those who were vaccinated at the veterans hospitals? Like, for example, those who are either disabled or those that had retired from the military. And I also had several veterans asking me if they received the vaccines either at regular clinics through their insurance, that actually the insurance was billed after the fact, or if they received it at the vet hospital without insurance being billed, if you compare those. And especially here in Clark County, several veterans are very active and they really want to do their job of protecting the public.
That is a great question. And I know I haven't looked at that for several months, but I know that veterans who got, this is an issue because we were trying to look at vaccination rates statewide, and veterans who got their immunizations at the VA, at a VA facility, were not entered into the WAIS. So the state registry, so the federal system did not communicate with WAIS. I think a veteran who gets their vaccination at a provider's office in the community, not at the VA, but at a pharmacy, that should be entered into the WAIS because those providers do so. But if they got it at the VA, that may not be the case. And I think what I would suggest folks do, and I don't have the answer for you right now, and I wish I did, would be to contact the Washington Verify and see if they can get their data entered in. But that's been, I know that was a problem at the beginning and an issue.
Thank you very much.
Hopefully have their vaccination card as well so they can use that.
Yes, they do. And they had shown to me, several of those cards, because we had requested that before I meet with them. I want to know.
That's been a challenge all along. And
Yes.
People get vaccinated in Oregon. That doesn't communicate with the Washington, or at least the last I checked, doesn't communicate with the Washington system either. But it certainly was a problem for veterans who got vaccinated at the VA in terms of getting into WA Verify. And I could check for you on that, or you could have them check
That'd
with
be
WA
great.
Verify. We gave you the number. They could find out how they can get their data
Right.
in.
And if you could check on that, because sometimes I do not get a phone call back from the veteran organizations. But if you could do that, that would be very helpful, because I think that is a data that needs to be captured as well, because they do travel outside of the country.
Yep.
Judy,
Yes, thank you. This is just a comment, Dr. Melnick. From what I've seen on Facebook and maybe when people were being interviewed on news, one problem is people think the vaccine came too fast, and so they say it's experimental. Now, I know that's not true. I saw this long 60 Minutes report that explained why we got it so quickly. It showed scientists doing all the work, et cetera. But people need to know, or you need to know, that that's what people think. And so if someone would, if that would be addressed, people explain to people why it did not come too fast. Thank you.
Yeah, those vaccines have been under development for a long time. And I believe, this isn't the first SARS-CoV, virus. So, we've had several other, this isn't the first one. So MERS, SARS, the original SARS, and then MERS, the Middle Eastern Respiratory, those are SARS, those were coronaviruses as well. So the development around the vaccine has been around for a long time.
Right.
And if we get a new variant, we're going to be developing it. But the other point I'd make around this is that there have been extensive phase 3 clinical trials. So what happened with this vaccine is that usually what happens with it when there's no hurry, when you're not in the middle of a pandemic, you do the phase 3 clinical trials, and then you do the manufacturing. You have time. So I can't speak for the pharmaceutical companies, But before the phase 3 trials are concluded, in general, they don't want to do the manufacturing, because what if the phase 3 trials don't show safety and effectiveness? Here, because of the pandemic, they started manufacturing large amounts of the vaccine while the phase 3 trials were going on. And the vaccine was not released until after the phase 3 trials were done, but it was ready to go because they had started the manufacturing process, large quantities earlier. So that was what made, a big part of making it, taking time off of it. But it's been through extensive, clinical trials. And honestly, besides the trials themselves, the real world experience with the vaccines have shown that they're incredibly safe and effective. And I didn't go into a whole discussion about VAERS with you. I think you probably heard me talk about VAERS before. This is one of the most scrutinized vaccines that we've ever
Exactly.
had. The VAERS system is a great system in terms of looking for needles in a haystack. Virtually everything gets reported of VAERS. If you break your leg, within a few days of getting the vaccine, that gets reported of VAERS. Everything gets in there, and people can report as well as providers. In fact, the CDC created an app where you can actually, if you get the vaccine, you can use it daily. I think it's called vSafe, and report what your experiences are. So everything gets in there. And then the CDC and the FDA, they're mining that database all the time, looking for patterns in there to see if there's an association between the vaccine, and they're seeing a pattern that develops. And honestly, these vaccines are incredibly safe. Yeah, go ahead.
My point was that it needs to be communicated over and over to people about that, about what you just said. Okay, thank you.
I've tried, but maybe.
But it goes beyond you. I mean, I think
It needs to be a national thing.
yeah, there's, again, I think an unfortunate misconception about what an emergency use authorization means. That doesn't mean, in the words of some of the anti-vaxxers, that it's experimental and that the public is guinea pigs.
Yeah,
You
the
have
other
to
thing.
show the same efficacy and safety. You just don't have the real-time, long-term safety and length of protection data that's required for full approval.
One thing I'd ask all of you is, you can testify at Board of Health meetings. I don't know whether you ever watch them. They're on City of Vancouver, cvtv.org. The public can, and the anti-vaccination group is very well organized, as you probably noticed. And I think it's great when they can hear from a broad spectrum of the public, when our Board of Health can, and those are televised. So you should all feel free to, to hop on and speak. Because I think a small minority, a very loud small minority, is drowning out the discussion. So, and you are all in touch with your neighborhoods and your community. So you're all leaders in the community. So whatever, feel free to participate in the discourse. Oh.
It seems like, that the organized opposition is there and they're coming to meetings and that sort of thing. The general public, which was relatively supportive of masks and distancing a year ago, has got to the stage where they're weighing the risks and benefits. And they're saying, it's not worth impacting my life to this degree for the level of risk that I have of getting maybe minimally sick. So that the sort of reinforcement the Board of Health got right at the beginning is sort of fading as people are establishing, what level of risk they're willing to live with. And they may be wearing masks, but they're not getting excited about the anti-vaxxers or, riots in Ottawa or whatever, and fatigue is a good word for it, because I think that's what's happening. And maybe that's what has to happen as we reduce the level of incidence of COVID, but it doesn't make it any easier for you guys.
Well, it's really hard on our hospital.
Yeah. Yeah. That's what happens. Just, yeah.
Anybody else? This has been great. Really fantastic. If, as long as Dr. Melnick is breathing and has the stamina, if we have any other questions, I'm sure I'll be glad to entertain them.
I just want to say thank you for what you've been through in the past year. You've been under attack multiple times and you've stood up for us and you've done a great job. Thank you.
Absolutely.
Are you ready to wrap the recording?
I think so. I think he's disappeared.
Yes, he
Okay,
disappeared.
I'm closing out the recording.
Good. Getting late.
Yeah, I think